Good morning. This is Dr. Nick Tulo with my Saturday morning live stream. I am very happy to see that a few people are watching, and that's really terrific. I tried to send an email blast to a lot of different people to see if you'd be willing to tune in. So I'm really excited about this morning. It's kind of a fun presentation. For those of you who haven't watched any of my live streams before, I am a cardiac electrophysiologist, and so I live in the world of ECGs. But I also happen to be kind of somewhat an AV geek. That's right. Actually, I'm wearing my Photoshop World t-shirt, shoot, edit, sleep, repeat. So I was at Photoshop World a few months back. I've been doing photography and video editing, audio recording. I have a recording studio at my home. So I brought my ECG expertise and my AV skills to YouTube and also to ECG Academy. So I hope that you enjoyed some of my discussions, since I wanted to bring my experience and knowledge and insight of reading ECGs to all of you, whoever's out there, because after all, electrocardiography, ECGs are throughout medicine. Patients need to have people interpreting monitors and rhythm strips and ECGs and Holters and 12-lead electrocardiograms. And unfortunately, most people are trained in such a way that they rely on pattern recognition. They were given a basic textbook, or they had a couple of lectures in school. And most of the time, if they look at something that doesn't look like the textbook, something that kind of is a little bit unusual, they'll find a colleague and say, "Hey, what do you think about this?" And my feeling is, if you have to ask someone else what they think it is, then you could use some additional training and more education. And I'm here to try to bring you to a higher level of proficiency. And kind of that's why I started doing this. We've been doing it for about 7 years, and it's been fun and very gratifying. And I think that this case today is a great example of what not to do. So anyway, I came up with this idea of Tulo's Law, which is don't believe anything you read on a rhythm strip unless you wrote it yourself. And the reason is, every time I open up a chart, I can always find rhythm strips that maybe were not labeled properly, because whoever looked at it was, unsure, and they just wrote down their best guess. But my job here is to try to make you think a little further, have you look below the surface, and not so much guess, but analyze and use a knowledge of the cardiac electrophysiology, the physiology of the heart and the conduction system, to figure out exactly what's going on. So I see we have a few people watching, and thank you so much. And Brian Gomez is someone who's been on before. Fuad, thank you. Jamshid Bahir. And Maya, good to see you this morning. I guess my emails went out okay. So anyway, here's the first strip that I want to show you guys. It's I see this kind of stuff all the time. And so this was just a random chart that I picked up. And here we see this sort of regular QRS complexes at a rate. It's let's see, this QRS lands on a heavy line, so 300, 150, 100. So it's between 100 and 150. It's about 130 beats a minute. Okay, and whoever read the PR interval in the QRS and the QT, noted that, but they put sinus tachycardia. And when you have a heart rate of 130 beats per minute in a patient who's not septic or febrile, or not doing laps around the nurse's station, the chances are that it's not sinus tachycardia. I mean, that's the first clue. 130 beats per minute is way too fast for most people to have sinus rhythm when they're just lying there on the monitor. So as soon as you see heart rates above 110 or so, you always have to sort of wonder, what is this? Now, when I first look at this, I kind of, look at the P wave morphology. Remember, after all, good morning, Osman and Nicola and Kaiman and Missy. Thank you so much for joining me. Yes, okay. So, and if you guys have any questions or something, please feel free to type it in. I'm going to check my chat box every now and then, but I'm not that good at doing it, so please bear with me. Anyway, look, when we look at a cardiogram, we expect a P wave to be followed by a PR segment. Okay, so the P wave is a discrete electrocardiographic signal coming from the atria, and there should be a flat spot afterwards. Now, granted, sometimes at faster rates, the PR interval shortens. Why? Because catecholamines, like adrenaline, that get the heart rate to go faster also enhance AV node conduction. So generally, sinus tachycardia is associated with a shorter PR interval in the same patient as, when they're just lying around resting and, watching SpongeBob. So, but there still should be a little spot after the P wave, before the QRS complex, that's known as the PR segment. And when you look at this, the P wave doesn't really have that. It kind of goes up and then gradually comes down, and then the R wave starts, and you have a small R and a very deep S wave. With a wide QRS, looks kind of like a bundle branch block of some sort. But you see what I'm saying is that you don't have a normal sinus looking P wave here. So that's the first clue. Well, actually the rate is the first clue. I guess I should correct myself. So I'm just looking at chat, so if I get distracted, I'm sorry. This is totally unscripted. I'm just kind of like winging it, right? So the idea of a heart rate of 130 in a patient who's resting and not like in bad shape, that's your first clue that it's not sinus tach. The second thing is you don't really have a PR segment, right? So this is a kind of a thing that you often see in atrial flutter, where you don't have a flat spot, you have like a gradual decline in the signal following the sharp point. So this rhythm could have certainly been atrial flutter or an atrial tach or something other than sinus tachycardia. And I always say that atrial flutter is a great imitator. Often 2-to-1 flutter will masquerade as sinus tach, 3-to-1 flutter will masquerade as sinus rhythm, normal sinus rhythm. And I actually have a really cool ECG that I'm going to be doing a chalk talk on. Oops, maybe that was a giveaway. I gave it away. Spoiler alert. Okay. Anyway, so I saw this and I was like, wait a minute, that's not sinus tach. So what's the best thing to do when you look at a strip like this and try to figure out, now you're on the patient's on the telemetry unit, right? They're on a telemetry unit, they're hooked up to a monitor, 24/7. I think most modern telemetry units have the ability to bring up a trend. A 24-hour trend or a 3-day trend or whatever, but it gives you the heart rate over the course of a long period of time. When I'm doing 12 leads, I always tell people, look at the forest first, then look at the trees. First, get a sense of the whole 12 lead strip to see if it's regular or if it's irregular or if there are premature beats here. You want to get the gestalt, the overall big picture. And why is the QRS inverted? It just they happen to be monitoring lead 2, and if the patient has a left axis deviation, it's going to be going away from lead 2. But that's but that's not important right now. A hospital, what is it? It's a big building with patients. So what was I saying? The idea is looking at the gestalt. So if you have a rhythm strip like this, what do you want to do? You want to see what happened before that, what happens after that. Look in your monitor, and a lot of people in my hospital don't even know which button to click on to find the trends, but you can find the trends. And so here is what the trends look like in this particular patient. So this is the heart rate on the left-hand side with 0 and 100 and 200. And let me just make that a little bit bigger. And I'm going to need a lighter color to write on. So you can see right here that the heart rate trend is mostly around, 80, 75, 80. Every now and then the patient gets up to go to the bathroom here at 6 o'clock in the morning and the heart rate jumps up. But this is what you need to be looking for. These sudden increases in heart rate and then resolving back to sinus rhythm. So when you see something like this sudden increase in heart rate, then you know for sure it's not sinus tachycardia. Why? Sinus tachycardia characteristically increases gradually, and then it decreases gradually. It's known as physiologic tachycardia because it's the autonomic nervous system acting on the sinus node and speeding it up gradually over the course of, a minute or so. So this immediately you should say, oh, this is not sinus tach. This is some kind of atrial arrhythmia. And so what do? You would click on the area where the heart rate changes, and then you'd click on the full disclosure. And so when I did that, I was able to print this out. So here you see that same patient with a heart rate here of about 140 beats a minute. I have to make a darker color. So you have a heart rate of about 140 beats per minute and a slightly widened QRS. But as you look past this first strip, you see suddenly the heart rate slows down right here. And then there's maybe a PAC here, and then you have a little flurry of activity, and then it slows down again, a couple more PACs. And so and then by this point in the strip, the patient's in what looks like a sinus rhythm. And down here in the bottom, it's clearly sinus rhythm with individual P waves in front of each QRS. You have a nice PR segment there. And there's a little bit of sinus arrhythmia, so it slows down a little bit and then speeds up a little, and here's a PAC. You see how if you click on the right spot in your trend, you can see how does the heart rate change? What's going on when the heart rate is changing like this? It's suddenly going up or suddenly going down. And you wouldn't necessarily call this atrial fibrillation because it's a little too regular. It very well may be an atrial tachycardia because you have these bursts, these salvos of PACs here. There's a couple, 3, 2, and so we've gone over stuff like this before. I think the last clinical live stream was about a woman who had incessant atrial tachycardia, and it kind of looked like this. But the point is that it's an atrial arrhythmia of some sort. I think it's a little too regular to call it atrial fibrillation, just because fib will generally be irregularly irregular. So anyway, that's how you can get to the idea, get to this diagnosis, and realize that it's not sinus tachycardia at all. It's an atrial arrhythmia. So so I have another case of a 45-year-old gentleman with a dilated cardiomyopathy who has an ICD because his ejection fraction is very, very low. And he came into the hospital because he was a bit dehydrated. And when the first trend that I saw, his heart rate was about 100, 105, and all the rhythm strips were labeled sinus rhythm, normal sinus rhythm, sinus tachycardia, though he has a dual chamber ICD. And so what's happening is the ICD is sensing every P wave and it's pacing in the ventricle. So this is known as atrial synchronous ventricular pacing. I've done clinical live streams about pacers and talked about how pacemakers work. And if you're interested in learning more about pacemakers, you can go on my big website, ECG Academy, and you can sign up for a course and you can learn a lot more about pacemakers. Certainly in the advanced section, there's a whole series of lessons on pacemakers and pacemaker rhythms. But at any rate, this particular patient had a pacemaker, and I'm just going to show you what the trend looked like. Now, remember, he had a heart rate of about 100, 105, thereabouts, and everyone was labeling it as sinus rhythm. And so here's what his trend looked like. Aha. Okay, so again, you have, let me just write in a lighter color. So this line right here represents 100 beats per minute. And then you have 0 and you have 200. Now, let me show you that other trend before, the other trend that I showed you here. Now, okay, this was where you had that the runs of atrial tachycardia. But notice that during sinus rhythm, there is a continual variation. It goes up and down and up and down, roughly between 10 beats per minute and so. There's a variation in the heart rate because of what? Because of sinus arrhythmia. And then when the patient gets up to move around, you have a gradual increase in heart rate, and then it gradually comes back down again. And then, every now and then you got a little bump in heart rate. So there is variation. Sinus rhythm varies from 1 minute to the next, even from a few seconds to the next. And so here at 11 o'clock in the morning, the patient maybe took a nap and their sinus rate kind of dropped down to around 70. Okay, let's go back to this one. Look at this one. It looks like, okay, so the trend is 100 beats per minute, but it looks like it was drawn with a ruler. I mean, oh my God, you'd never see anything like this. Look how straight that is, like a ruler. Right across here, and this whole area here is just one straight line. But here's the clue. Every now and then, the heart rate drops. It drops down to like 70, and then it goes right back up again. So look at this crazy rhythm here. You don't see this very often, but when you see a straight line like that, it has to be an arrhythmia. It can't really be sinus tach when it's that regular. And what clinches the fact that it's an arrhythmia is the fact that every now and then the heart rate suddenly changes. Now, sometimes people who are in really bad shape, they're really septic and they have a lot of catecholamines, their autonomic nervous system, the sympathetic nervous system is revved up, and their parasympathetic nervous system is like on standby. So parasympathetics usually cause rapid, abrupt changes in sinus rate. That's what causes sinus arrhythmia, right? Even respiratory-related sinus arrhythmia. And so when someone is septic, you may see relatively flat heart rates in the range of 100, 150, 110, 120 beats per minute if they're really, really critically ill. But you don't see that with normal people. This is clearly not sinus rhythm because it's so flat. And then what clinches it is that you have these drops in heart rate. So let me show you what the drop in heart rate look like. So you click in there and you zoom in, and here, look at the top here, how slow, and then it suddenly goes fast. And I mean, I can zoom in a little bit into the part that where it suddenly changed, where here you have a heart rate of about 70, and then suddenly the heart rate's 100. You see that sudden change? You know it's not sinus as soon as you see that. That's the dead giveaway. So when you look at his 12 lead, remember I told you he has an ICD, it's dual chamber, so every time the atria contracts, it paces in the ventricle. And so this here you see a heart rate of just over 100 beats per minute. And there's a pacing spike in front of every QRS complex, but the pacemaker is obviously tracking something. It's tracking a P wave somewhere. But then we managed to look back at his older tracings, and you can see that on the older tracings, he clearly has a P wave, and the heart rate is in the range of like 60, in this case, 60 beats per minute. And in this case, the other case, it was 70 beats per minute. So this is a person who has intermittent sinus rhythm, but he also has a very, very slow atrial tachycardia that is steady as a rock, very, very stable, and gives you the appearance of this flat line on the trends. So this is something that's like really important. Look at your trends, because you can get so much information from the pattern of the heart rate, because sinus rhythm will not change abruptly like this. In this case, he was almost all day long in this atrial tachycardia at 100 beats per minute, but he looked fine, and everybody assumed it was sinus rhythm. until you look at the trend. Nobody looked at the trends, and that's why we finally realized that he was having an arrhythmia, and we started to talk about using antiarrhythmic drugs, maybe increasing his core egg a little bit. He wasn't symptomatic. That was the other thing. With a heart rate of 100, he felt absolutely fine. His blood pressure is fine. He didn't even realize that he was having this arrhythmia, but the trends gave it away. So anyway, the point is, even when you think it's sinus rhythm, look a little bit further, because heart rates over 100 beats per minute are very rare in people in a hospital bed. Like I said, unless they're in a critical care unit. If they're just sitting on telemetry, watching TV, their heart rate generally is not going to be above 100 unless, there's some other reason. Obviously you want to look for something. What the three most common causes for sinus tachycardia are anemia, fever, even thyrotoxicosis. Everybody gets a TSH when they have a heart rate like this, but most never shows anything, right? When was the last time you caught a case of hyperthyroidism just on that basis? So at any rate, this is an important lesson. Use those trends, use other kind of physiologic clues, understand the physiology of the sinus node, and then you be able to look at a strip and say, no, wait a minute, that doesn't make sense. This can't be it. What else could it be? So this is my Saturday morning live stream. I hope you enjoyed it. I just want to let you know that if you enjoy this content, then definitely subscribe to my YouTube channel, which is in the link below, and let your friends know, let everybody else know that for most Saturday mornings, I'm going to do these at 11 o'clock. I'm still in my office with a bright window behind me, but when I get my new recording studio down in the basement, it's going to be a little bit nicer, but I'm going to still try to do these every week so that you guys can gain additional insights into how to read a cardiogram, how to understand arrhythmias the way I do. And if you're interested in learning more, you can always check out ECGAcademy.com. That is the link in there is also in the description down below. And it's a great course for anyone who knows the basics but wants to understand it even better. My job here is to get you guys to become resources at your hospital, in your practice, people in training, students, and even people who are functioning in hospitals. You could always get better at what you're doing. You want to be an expert in what you're doing and not have to rely on, hey, what do you think this is? Right? Then you can teach other people, and you can become the expert on your unit. So one last check at the chat. Let me just make sure. Many in my hospital would say that it cannot be atrial tach unless the rate's 140. Well, that's ridiculous. Granted, most supraventricular tachyarrhythmias are higher than 130, but this is clearly an example of an atrial tachycardia that's not over 140. So you can't draw lines in the sand. You can't be so dogmatic. You can't use silly rules like, well, if it's irregularly irregular and it's wide, then it must be AFib with aberrant conduction. Ooh, that drives me crazy when someone says that. And telemetry techs will argue with me that, oh, well, that's the way I learned it. That's how we do it here. So just because you have a heart rate of 135 does not rule out an arrhythmia. So that's ridiculous, and you need to try to educate your colleagues and get them to understand that kind of a guideline just makes no sense at all. So let's go back and see. Let's see. Christoph says, how can you be sure it's an atrial arrhythmia? You don't see P waves. Could be junctional arrhythmia? Usually not. Junctional arrhythmias like this are really, really rare. And they usually are an automatic junctional tachycardia, like an accelerated junctional rhythm. They're usually not so rapid, so quick in onset. It's usually gradually overtakes the sinus rhythm and then gradually sort of like goes away, or the sinus rhythm kind of speeds up and overtakes an accelerated junctional rhythm. So even though you don't see P waves, probably the P wave is buried in the previous QRS complex. So remember that P waves can hide, and you can't always, like I said, junctional rhythms, junctional tachycardias are actually quite rare. And I would assume that it's an atrial arrhythmia just based on the way it behaves. Let's see, what else? You could read out his ICD. That's exactly what happened. We looked at his ICD, and I could see that there were P waves there. And so, I mean, I knew what it was just from looking at the trends. But the ICD is a good way to monitor whether your therapy works. So you can come back and you can take a look at heart rate trends. But keep in mind that as far as the ICD is concerned, you have a pacing rate, a lower pacing rate. So anytime the rate falls below that, it's going to pace. And it'll keep track of how often it paces. But then you have an upper rate, which is usually the VTach detection rate. Okay, which could be 150, 160, 170 beats per minute. Anything in between, as far as the ICD is concerned, it's normal. So it's not going to alert you to heart rates of 110 or 120 or even 140. Sometimes you can program on a monitor zone of 140, 150, whatever you like, to see how often the patient goes into that zone. It won't deliver any therapies, but you can at least track how often the patient gets into that zone. But most of the time an ICD will treat this as a normal rhythm and won't even recognize it. It won't log it. So there's kind of no way to know from the ICD interrogation that this is even going on. So yes, let's see if there are any other comments that are protocol of electrode application for Holter. Well, there's actually a series. If you go onto ECGacademy.com, you can sign up for the free introductory membership, which is 2 months free access to like the first 6 sections. And in that, there is a section on the cardiac conduction system, electrophysiology, and also how ECG machines work and how to apply the electrodes, where to put the electrodes on the chest wall, and so forth. So that's a great way to just check out the basics, and it's free. And you can also find those same videos in my YouTube channel, ECG Doc. So that's actually a pretty popular one that people have watched. I don't think there are any other questions, and I thank you all for spending your Saturday morning tuning in. And for those of you watching after the fact, thanks very much. And again, keep track of the Saturday mornings. I'll usually send an email either the night before or the morning of, because if I'm not on call, I'll try to get it done. So now I wish all of you guys a very happy New Year as well. And I hope you're enjoying the holiday. And it's a little chilly up here in New Jersey, but we're all looking forward to 2019. I hope it's going to be a great year. Let me just see if there are a lot of other comments. My ICD says I'm in VTach almost constantly. Well, okay, that could be. So again, ICDs, if you program an upper rate limit of 150, the ICD will just treat that as abnormal. And then there's a backup. There are morphology discriminators that can help avoid getting treated for sinus tachycardia. So, but that's a whole another conversation. So anyway, thank you again, and happy holidays and happy New Year to all of you. And thanks again so much for being part of this clinical live stream. Have a great day.